Scan it with your WhatsApp camera. You don't need a scanner. And join that group. Be ready. At the end of it, we'll put a poll. And the poll, you can choose the best team and best individual. Okay, 2 polls will be there. And you can see it yourself how many are getting the vote. Just don't go and look at the total and then vote. Just vote blindly. Everybody can see, and it is very transparent, nothing hidden in it. And the audience poll will be fully transparent, 100%.
Good afternoon, everyone. Welcome to the OPL 2023 of the Golden Jubilee Annual Conference of Kerala Society of Ophthalmic Surgeons. See, we are reintroducing OPL in our annual conference after a gap of 10 years. So I've been moving around in different state conferences during the past 1 year. So I was in BOA conference, wonderfully organized by Ragini ma'am and Lahane sir. See there, it's not such a big hall, but the hall is packed. So then I realized this is something that is very attractive to everyone. And so that is why I decided we'll have it this year. And I have seen Mahibal sir participating in OPL and winning and conducting OPLs. When I didn't have to look beyond him to get the anchor for the OPL. And thank you, sir, for agreeing to be a part of this. Just to introduce sir. Sir is the promoter and founder of Center of Sight of Eye Hospitals, senior consultant, chairman, and medical director of Center for Sight. He's a Padma Shri awardee, past president of AOS, recognized globally with fellowships and scholarships, pioneered in India the technique of phacoemulsification and LASIK, conducted and performed several live surgery demonstrations in the remotest locations of India, and ensured that the Indian flag remains flying high in the domain of eye care. I request sir to take over.
Please. Thank you. Thank you, Srini, for the kind words. A pleasure to have the OPL at Drishti 2023. And without much ado, I'll wish to call the referees and the judges on the dais. So a big round of applause for the judges. Dr. Lahane, please, sir, can you join us? Ragini Parekh and Dr. J.K. Reddy, please. So they are the guys who have been given cryptos. Dr. Lahane, how many cryptos you got? Bitcoins. So the teams are fully allowed to give them in whatever currency you want. You can bribe them, you can harass them, you can terrorize them, whatever you want, but they are going to be giving you the awards for your presentation. And we have 2 referees from the Kerala. So Swagatam sir on the dais. So let us have Dr. Rajiv and Srini. A big round of applause for the referees to be on the dais. So friends, the rule for this are that there are 4 teams and they will be taking out a draw of lots to take as to on what number they come. And may I request the team, there's a mentor in each team and there'll be 3 presenters. So they have a total of 13 minutes, 1 minute for the mentor to do whatever he wants, to introduce them, to make fun of them, whatever you want, you can do that. And 12 minutes for the 3 team members to make their presentations. So that is going to be the 4 teams. So can I have the mentor and the captains of Team Travancore, Dr. Mahadevan and Meenu, please, on the dais. अभी कर रहे हैं यार, कर रहा हूँ. Team Kochi, Dr. Elizabeth Joseph and Dr. Natasha. One second, just hold on. Yep. And then we have Thrissupurur, that is Dr. Anthra Rose and Dr. Lathika, please. And Malabar, big round of applause, Dr. Padmaja and Dr. Bindu. So can we have the teams here? Yeah, all the best to everybody. And we have them in great costumes and everything. So can we have the starting video before we take on this? Can we have the videos, please? Yeah.
बैल जैसे धूल उड़ा के सींग उठा के तुम भी नाचो, बाज जम के ताल ढोल बेटा राजू उड़ के नाचो।
हीरो से भी तेज कोई कर सके जो भेद नाचो,
अस्तबल में घोड़े जैसे भाग डोर छोड़ नाचो। मिट्टी जो रोट मोटा मिर्चा खा के ऐसे नाचो। हाँ जा छोरे,
हाँ जा गोरे,
हाँ जा छोरे, नाचो 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 वीर नाचो, नाचो 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 यार नाचो, नाचो 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 कच्ची कैरी जैसा खट्टा नाचो, नाचो 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 बिच्छू काटा लागे ऐसा नाचो।
पुदीना देगा, नाक ना गिना देगा, चिकनी चमेली देखी चिकना कमीना देगा, छानने चिडर होके चीट किया तो सारे तारे बोले गिली गिली अक्खा। बदतमीज दिल माने ना बदतमीज दिल माने ना
Thank you very much. And friends, we will now have the draw of lots. So can we have the first team, Team Travancore, please? Just take out a lot. Can you open that? So you go number 3. Okay. No, that's wrong. You go number 3.
We go number 3.
Yeah, your team goes number 3. Okay. Can we have Team Kochi? Yeah. Just take out what number? Number 2. So Team Kochi goes number 2. Can we have the next team, that is Trisuran Parur? Yeah. Trishur Parur. Trishur. Trishul or Trishur? Number 4. And we have the starting with the Malabar team. Malabar. So ma'am, I think that should be number 1. Until of course we have fudged it. Yeah, that's number 1. So can we have all the teams ready, please? Timer, 13 minutes, we'll let you know. Just to tell you the rules and the awards. So you guys have to also do the awards. And let us see how well these judges who have been bribed, semi-bribed, fully bribed, how much they agree with you or not. So the awards will be decided by the judges as also the audience. Though there is going to be a team award by the judges, which is the Kerala OPL 2023 champions. And then there is a second award, which is Kerala OPL 2023 runners-up. So judges, the team, best team, and the runners-up. And then there are individual awards. So overall performance of an individual, whether it is entertainment, whether it is scientific, everything combined together, whether it is the costume, the presentation, whatever. So Kerala OPL 2023 individual champion, judges sir. Then Kerala OPL 2023 individual runners-up. And then there is one award that you have to give, that's for the best scientific presentation. Only science, no bakwas. And the second is only bakwas. That is the most entertaining presentation for the Kerala OPL. So that is for the judges and the audience. You will have a QR code that will be shown in between. Can you show the QR code even now? So you can scan this QR code and from your phones you can send as to whom you want. So one would be the best team, then runners-up team. So you have to put them 1, 2, 3, 4. In the team's side, do you have to put them 1, 2, 3, 4 or what? Sorry? No, WhatsApp poll is fine. So how do they mark for the best?
Sir, I'll explain, sir. See, there'll be two polls in this. One is for the best team. You join the group, then the poll will start. All the names of the 4 teams will be there. See, you have only one vote. So you vote for your team. See, it'll be displayed here and you can see it on your phone also. Okay. One vote comes, it comes, and it's very transparent. You'll see it on your phone. You will see it here. We can't be bribed.
No. So basically it is going to be, they have to poll for the best team, that's it, and then you total for the maximum number of people who are in the best and the second. Okay, exactly. So that's it, you have to do the best team. And similarly, you have the best individual, and you have a runner-up team, and you have the best individual presentation and the second best individual presentation. So, okay, those who have been able to do it, we'll show it in between also. So, is the first team ready? Which is the first team that has to come? Can we have them on the dais first? Malabar. Team Malabar, please. Kahan bhag gaye? Arre?
Yeah, they're hiding.
Arre, you are here. Come. Okay. So please, ma'am.
All the team members, please.
Can we have all the team members? Just to introduce all the team members. Dr. Padmaja is the mentor. She will be commenting on it. Dr. Bindu, Dr. Prakash, and Dr. Sujit. Okay. So big round of applause for them. And so your time starts now. 13 minutes, sir. So can we, 1 second, ma'am, are you ready? Ma'am, are you ready? Yeah, can we have the timer, 13 minutes? 1 second.
You show that, na? You have to stay with madam. You have to stay.
What happened? Okay. 1 second, please. So friends, you can be ready to pull anybody's leg. Don't mind if I am a little off the record because I am a little high today. But any captain can pull any other team member. So be ready with your witty criticisms. Sorry. Are you ready, please?
We'll pause in between.
Are you ready? Are you ready, ma'am? Okay. So please start the timer and all yours, Team Malabar, please.
Good afternoon. I present before you my invisible team of Kalaripaita warriors. Watch them fight, watch them win.
From the land of immortal myth and legend, I bring you my 3 brave, unconquerable warriors of Team Malabar, who will battle the evil forces of darkness and overcome everything in their path to restore glorious vision.
And now we go on to the very first battle of my first warrior.
The idyllic and peaceful beach of Kapat today. However, 500 years ago, Da Gama lands here in search of spices and treasure. He is greeted with traditional Malabar hospitality, but he repays this cruelly with violence and killing. A young boy watches his father killed by Da Gama's men and vows to kill Da Gama himself, growing up to be none other than Chirakkal Perli Nayanar, the legendary hero who fought the Portuguese. Now cut to the present and watch another brave Nayanar as he battles the invasion of his sacred turf, the Cornea.
Yes, is the mic on? Yeah. Yes, we present a case of total limbal stem cell deficiency in which we have done a SLED procedure. This lady was suffering from corneal blindness for last 27 years. So 27 years of invasion of cornea, untouched. So we had to battle it out, and it was a fierce, bloody battle. We have to cut out 360-degree peritomy, find out the invading fibrovascular pannus. Minimum cautery was done to prevent the ocular surface, and the invading tissues were dissected out. Those crescents were our swords, and we dissected out. It was a deeper invasion. We have to take it out neatly without touching the cornea plane. We didn't want any of the normal tissue to be lost. Though it was a long invasion, we could clear out the invaders. God-given best healer, amniotic membrane, was put on to prevent the haze and scarring. All our warriors and the borders were lost, the limbal stem cells. So we had to take it from the other eye. 2 clock hours of limbal stem cells were taken from the other eye without affecting the donor eye, and they were cut into small pieces. The small segments were kept along the boundaries to prevent the re-invasion of our enemies, which we are sure they will come back with vengeance. The structural integrity was maintained. Now let us see what happened functionally. Preoperatively, she was hand movements close to face. In 1 month, it cleared 636 vision. 2 months, 618. Fundus was clearly visible, and in 3 months, we could restore 6-9 vision. And we could restore functional and anatomical cornea for that patient. Thank you.
Now on to the second battle, where my brave female Kalaripaita warrior is going to start.
So the present battle for me was a young male who presented with bilateral refractive glaucoma and retinal detachment surgery. He was referred as secondary glaucoma. I just thought, is it stickler again? Because I was just reminded of the previous battle where I had to deal with the pressures in both the eye in post-retinal detachment surgery. So the story begins when a boy presented with retinal detachment and post-surgery he was referred for secondary glaucoma, but then we saw the pressures were high in both the eyes. In addition, he had hypermobile joints with history of retinal detachment in his mother too. In spite of all the measures to control his pressure, the pressures were not coming down. So I had to go and do a trab, but as you know, the silicone oil was wandering around everywhere, even under the bleb, causing the fibrosis. And in spite of all the measures, it went into a failure and still it had the pressures very high. So then I had to go and do a Ahmed valve in this patient and thus control the pressures in him. But then the story doesn't end here. 2 years later, he again presented with a drop of vision. Here the challenge was to keep a toric lens in a silicone-filled eye with a tube in place. Yes, I could achieve it with 6/12 vision and IOP of 18. And to summarize, here is the patient with RD with bilateral glaucoma and suspicion of stickler. I ordered a genetic analysis test and the result was stickler syndrome. With the learnings from this battle, now I prepare myself for the next battle with a similar history, with pressures high in both the eyes and post-retinal detachment surgery. So now I know silicone oil will not leave me alone, so I go and do a diode to control the pressure. But the real challenge was the other so-called normal eye, where the pressures were not controlled in spite of intravenous mannitol, where I had to resort to decompression vitreous trap followed by trabeculectomy. Again, with a history of retinal detachment and secondary glaucoma on both the eyes, is it stickler again? But then the result was a surprise to us. It was an Aicardi-Gautier syndrome with Singleton-Merten syndrome. And that was a difficult fight and difficult battle too. This gene is associated with 2 immunogenic disorder which is associated with glaucoma. This boy had a normal early development followed by neurological regression and delayed psychomotor development, and on brain scanning also showed calcification. That was symptoms of Aicardi-Gautier syndrome. And then on examination, again he was found to have dental anomalies and psoriatiform rashes which are suggestive of Singleton-Merten syndrome. Actually, he was taking treatment, indigenous treatment for a resistant dandruff, and that was diagnosed now as psoriasis. So is there a phenotypic overlap? Yes, in the journals we could see such phenotypic overlap. Now what did we gain and what did the subjects gain after doing a genetic analysis? In the first case, his mother and sister tested positive. We could offer genetic counseling. And the second case, we could get a proper diagnosis and send him for a proper treatment. And thus the victorious Unyarcha is happy with the Praja. Thank you.
Invasion, invasion, invasion. I don't like invasion, but this was a one-eyed patient who was only seeing eye, had a CNVM in his eye. You see in the center on the royal throne is sitting the CNVM and the grand entry of intravitreal injections. 1 injection, 2 injection, multiple injections. The things were going very well for the patient and almost the CNVM was to be conquered, and at that point of time, something bad happened, something unsuspected happened. That was a massive subretinal hemorrhage in that patient's eye, and this patient's only seeing eye was threatened to lose complete vision. And that is the time when the warrior decided to use what is known as in Kalaripayat as Puri Katagan, or the final gambit, the final tactic. That was the only way out for this patient, and the battle was fought inside the vitreous cavity of this patient. A 25 gauge vitrectomy was used to approach. The first line of defense was a breakthrough vitreous hemorrhage, as you see that white screen of vitreous hemorrhage, which was cut and removed mercilessly. But to our horror, we found the second line of defense, that is under the retina. There is a large submacular hemorrhage, and the villain of CNVM was hiding behind this retina. Retina was cut after cautery, inferior 180-degree retinotomy was done, and the retina was folded over it to reveal the subretinal hemorrhage. The inferior 180-degree flap of retina was folded over it, and you see then a bloody battle ensued. The whole blood was inside. It will take only a few seconds here, but it took almost 1 hour for the surgeon to remove that blood. And finally, and in between the cataract offered some resistance, but that was tackled with a phacoemulsification, and that gave us more clarity to see this villain, that is the CNVM under the macula. And now we could visualize the CNVM very clearly, and that CNVM was caught by its leg and pulled out and removed and cut completely. But then that doesn't end the problem. There are many other villains inside. There is subretinal hemorrhage stuck under the retina, those whitish material that you see. So all this has to be meticulously cleaned slowly so that some kind of anatomical integrity is achieved. But then we saw this, what you see there, the geographical area of gray color, that is RP completely gone. The villain has already done its damage. It has removed the retinal pigment epithelium completely. So we used our reliable warrior, PFCL, to put back the retina, hold the retina from the field of battle, so that we could take a healthy retinal pigment epithelium which was present on the nasal side. The nasal pigment epithelium was cauterized gently, and it was cut with vitreoretinal scissors from the underlying choriocapillaris and choroid slowly. And then it was using a forceps slowly slide under the PFCL to bring it under the macula without causing any wrinkles or anything on it. And our trusted friend, the PFCL, was put on top of the retina now to make the retina flat, and the edges of retina was fortified so that another invasion like retinal detachment doesn't happen. After fortifying the retina, our trusted friend, the PFCL was removed and replaced with oil, that is the PFCL oil exchange was done, and the eye was closed. So even though battle scarred, as you see in this picture, there was a good macula which gave this patient ambulatory vision, and though this patient who was destined to be blind could have some ambulatory vision and still could do his activities. Thank you. Thank you very much, and a big round of applause for Team Malabar for the excellent presentation. Boss, no entertainment, only serious stuff, no bakwas. What, they should know OPL also as bakwas, no? What do you have to say about their presentations? Can I have the next team ready, please?
I think they have done a wonderful job, but they have mixed the academic with the Kalaripait or Nadangala. We believe in academic, not in business. So you wait for our presentation.
Oh, okay.
All the best for the team.
So you vote for them, huh?
No, I am.
So you have won already, boss.
No. We are all sitting a positive thing only.
Only positive thing. No leg pulling.
Professional.
Okay, a big round of applause for this team, please. They did a great job. And you can in your minds think about what marks you want to give. Thank you very much. We have the...
Good.
Sorry? Intro will be part of 13 minutes. Just wait. So anyway, this QR code is again for you, and we have... Oh, wow. All blue. So you have the Avengers, huh? Natasha, Avengers? Whom are you going to avenge? The world. Okay. Okay, come. So you are ready? So we have the Cochin Avengers, and ma'am, we have the 13 minutes for them. Your intro video will be part of that. Yeah, just wait on whenever you are ready. So, audience, you have to vote for best team, best runner-up team, best individual presentation, and second best individual presentation. Okay? Are you ready? Yeah. Sure? Chalo. You want to start from where?
We are Cochin Avengers.
Can you put
the
the timer on?
superheroes of modern times? We are here to fight the ancient 18th century warriors. Here are our team. Our captain, Dr. Natasha, Dr. Gopal, Dr. Marian Polly as our members, trying to save the world.
Now might be a really good time for you to get angry.
That's my secret, Cat. I'm always angry.
Now we come to academics.
Okay, can we have the first video on? As with these august judges here, I did not want to shave off the cones out of the retina and then put PFCL. Can we have the videos?
Video.
Yeah. So this is a case of a macular hole which is enlarged after a subretinal hemorrhage has been removed, and this hole with tissue loss. So how can we constructively improve the tissue? You can see there is an ILM peeling which is already done. You can see this hole with the ILM is already gone. So how will you get it? So you go inside, you remove the part of the vitreous which is still remaining, any part of the vitreous which is still remaining, put in a brilliant blue just to make sure that we have completely removed the ILM. Stain and see. We decided that we will do an area from which graft will be taken and transplanted to the macula. Lasering there, PFCL, stabilize the globe so that the graft can be taken peacefully without any problem. Diathermize the edges of the graft. Now, once the graft is slowly disengaged from the rest of the retina, that is taken and slowly under the cushion of PFCL moved towards the macula where there is already a tissue loss. So this is a peripheral retinal graft which we are slowly harvesting, and then because there is a lot of choroid is very vascular there can be a lot of bleed from there, so we have to carefully separate it, and then we slowly move that under the PFCL without turning right towards the center, and it has to keep its place in the macular hole. So this will initially it will be just there, but slowly it will integrate. The cells in this will slowly integrate with the central area, and then you have to position it. You need not insert it below because it will cause a lot of damage, because functional visual acuity is important, not just anatomical localization. Now what we have to do is to do a direct PFCL silicone oiling exchange. So for that, I just put one more port for an endo illuminator. A chandelier has been put there so that my both hands are free. With one hand I use a silicone oil, other hand I will use an aspirator and aspirate the silicone oil as well as aspirate the PFCL and inject the silicone oil. You can see that's a PFCL bubble at the end, and without translocating that particular graft, we are just going to remove that final bit of PFCL, and the graft remains there, and the silicone oil is filling the globe. So that's the end of surgery. So silicone oil filled eye. Currently, the patient is positioned, and first post-operative day, we just looked at the overall picture. That's the first post-operative day fungus, and then the OCT, and the patient came back 3 days back with about 6/36 vision. Over to you.
The next presenter, please.
Fortune Avengers presents the blink. Facial nerve palsy can be complicated by the sequelae of lag of ophthalmos and decreased blink, which in turn can lead to chronic ocular surface irritation and blindness. Even though various static procedures have been described, dynamic eyelid reconstruction has attained a particular momentum in the management of facial palsy. In this video, we demonstrate the dynamic procedure of orbicularis oculi muscle transfer, where the normal orbicularis is transferred to the paralytic side. Skin incision is marked on the unaffected side and incised with radiofrequency cautery. Subcutaneous dissection is done to separate the orbicularis muscle. Dissection done superiorly and inferiorly to separate a part of preseptal and pretarsal orbicularis muscle. Lateral raphe dissection done to separate the muscle from the lateral canthal region. The muscle is incised to raise the flap. Care should be taken to avoid injury to the underlying septum as well as tarsus. The flap has been raised by keeping a wide base medially. Skin incisions are made on either side of the bridge of the nose above the medial canthus. The flap is tunneled subcutaneously through these incisions to the affected side. For the ease of tunneling, a small central incision can be made. Once the flap is tunneled, it is divided longitudinally into two halves for the upper and the lower eyelid. Side cuts are made to increase the length of the flap. The flap is attached to the paralyzed orbicularis with the help of 6-0 vicryl through small skin incisions on the upper and the lower eyelid. The skin incisions are closed with 6-0 vicryl and ethylone. 45-year-old female presented to us following tumor excision. She underwent orbicularis oculi muscle flap along with retractor release. We can appreciate the improvement in the blink as well as the lag of ophthalmos. Orbicularis oculi muscle flap can be used alone or as an adjunct to other procedures in the management of facial palsy with good functional and cosmetic outcome.
That was a great presentation. We decided about improving the function too. Not only blink, but wink also. Now next.
I want all of you to just close your eyes for a second. I'm going to tell you a long story of perseverance, persistence, and personalized pediatric eye care. Think of a 10-month-old female baby with abdominal distension, recurrent loose stools, progressive skin lesions, and failure to gain weight. Pallor, edema of the hands and feet, T-pigmented hair, hypopigmented scaly skin lesions, oral candidiasis. And they were sent for an ophthalmic examination. Now open your eyes and see what the baby had. Bilateral festoon pupil cataract and no view of the fundus in both eyes. Examination revealed anemia, hypochromic microcytic anemia. Skin biopsy showed granulomas. Liver biopsy showed granulomas. The colon showed, this is the histology specimen. The colon showed granulomatous colitis. Duodenum had granulomatous duodenitis. And the baby was in trouble. And our diagnosis was Blau versus infantile sarcoidosis. And this story began in 2013. And now we put the baby on systemic immunosuppression. Blau it was not, because NOT2 mutation was negative. Started on methotrexate, then MMF, then topical steroids were tapered off. First 4 years I have seen only the optic discs, because I could not see even under anesthesia anything further in the fundus. And after 4 years, in 2017, there was a vision drop with 612 in one eye, 636 parts in the other eye, and exacerbation of uveitis, and we put the baby, another problem to tackle, and we put the baby on adalimumab. And after control of inflammation, the baby underwent cataract surgery in the left eye first. Now there was disc pallor, multiple sheath vessels in the fundus, but still she had good vision at 618. But disaster struck. Left eye, there was an exudative retinal detachment that refused to get settled. We put the child on, we advised Ozurdex, they were not ready. We tried IVMP, we stepped up the immunosuppression, nothing worked. The sensory neural detachment with the vision remaining 618 continued for so many years, till 2020. And in 2021, the child had high IOP, open angles, and needed trabeculectomy. Another surgery she underwent in the left eye with the SND still persisting. Nothing we could do to save that SND. And in 2022, now vision dropped in the other eye to 6/60 due to cataract. And the child underwent a cataract surgery in the right eye, and then again in the left eye, the first eye which had the SND, vision now dropped to 2/60. And we had to think that there is a small regma somewhere. That is what is causing that detachment. So we went ahead with retinal surgery, PPV with silicone oil, and this is the post-operative picture with the retina attached, and the baby is maintaining 6/60 vision. We have a long way to go, 6 surgical procedures, but we are still holding her eyes safe. And last World Sight Day, she gives me this picture because we, rheumatologist and I, have been taking care of her eyes through these 10 years. Thank you very much.
We conclude Team Avengers to win.
Thank you very much, and indeed a big round of applause for the Kochi Avengers. Meenu, yaar ye kya, Gopal, what nonsense here? I taught you how to do corneal grafts. Corneal grafts? Yes, in RP Center. And now you are putting retina, you make a mound on it and say vision is 6.5. 6:30. Meenu, 6:36. Tomorrow it is going to be 6.5. No, that's what you are going to tell them. Meenu, what do you feel of them?
The thing is, one OCT was shown, just like a tree growing. After some time, it will grow, poothu pandalichu kai okke aayittu varumbo, patient will be very happy. Another vision onnum kaanichittilla. Some saana adinathu ñekki ketti vechu ennokkeyana parayunnat. അപ്പോൾ അത് ശരി ആയിക്കോട്ടെ, ഇപ്പോൾ ഇന്നലെ ചെയ്താണെന്നാണ് പറയുന്നത്. അപ്പോൾ പിന്നെ നമുക്ക് ചോദിക്കാൻ പറ്റില്ല. പിന്നെ Natasha is holding on to that patient for so long, and something they do so that they can do something later, calling again 2 years later, again calling. And again doing something. She said it is waiting. So many years are there. ഞങ്ങളുണ്ട് പിന്നെ വന്നാൽ മതി എന്നാണ് പറയുന്നത്. പിന്നെ ആകെ somebody was blinking nicely, and then they did something on the lid and then glaring at everybody. He was keeply blinking at people like this and walking. What? Yeah.
She didn't show blinking. She showed winking.
Winking.
Exactly. Aankh mari na madam. You wanted to tell? You can for 10 years at a stretch. Yeah.
Okay, so nice. All the best.
All the best. Okay, a big round of applause for the team Kochi, please. Big round of applause. And judges, you can do the marks. Audience, if you want. Has everyone noted down the QR code? It's your phones, or you want it again and again? Okay. So we have the third team now, and the third team is Team Travancore. So are you ready? Yes, sir?
Yes, sir.
We are ready.
Okay, their time starts now.
We'll have the intro video on, please.
Yeah. Can we start? We don't show simply fake film. We straight away, we talk less and show. and perform. Ladies and gentlemen, distinguished guests and esteemed judges, I stand before you with immense pride as the mentor of these illustrious Travancore Royals. Today, we are embarking on a journey of knowledge, innovation, and regal brilliance. And brace yourselves for a presentation that transcends the ordinary, as our young prince and two queens take you on a regal journey, a scientific symphony in the form of a 4-minute paper presentation. The stage is set for Travancore Royals to enthrall this audience. I ask our first speaker, the regal Rani Ambika Shetty, an energetic acrobat in the OT. She can perform surgery even in the upside down position. Ambika Shetty.
Namaskaram. Picture a wheelchair-bound mother with her sons living abroad, her world eclipsed by the shadows of her diminishing eyesight. Join us as we embark on a journey that will liberate her from her sightless existence. We know the challenges of cataract surgery in a brown cataract, but imagine that in a patient who is morbidly obese. Her systemic comorbidities and short neck make her a high-risk case for general anesthesia. As we prepared for her cataract surgery, during the mock drills we noticed that supine positioning causes a lot of stress and anxiety. We considered the various positioning options. Due to a flexible spine, we decided to go ahead with patient sitting and the surgeon standing. The patient was counseled and also told that she has a higher risk of complications. We tried to make the patient comfortable by making a headrest for her, which could be attached on her wheelchair, and also we arranged some cushions and a foam board to improve the patient's support and comfort. Counterbalance was provided with the foot support. We also made arrangements to ensure that her vitals were monitored during the procedure. The microscope was elevated and raised to the maximum elevation. The objective was tilted towards the horizontal and the eyepieces were adjusted, and minimum magnification was used throughout the surgery. Under peribulbar anesthesia, we decided to go ahead with phacoemulsification. Throughout the surgery, the surgeon had to place one leg on the foot pedal and the other leg was used for balance and stability. The ergonomics was slightly challenging. Once we started the phacoemulsification and split the nucleus, we noticed that the pupil started constricting. So iris hooks were used to dilate the pupil. At this point of time, there was high positive pressure noted, and then keeping in mind the safety of the patient, the decision was taken to convert to SICS. A scleral incision was made and an entry was made. The wound was extended. Liberal injection of dispersive viscoelastic was done. The nucleus was slowly prolapsed into the anterior chamber. So while doing a sitting cataract surgery, one has to remember that there is more outflow than the inflow. So that is why we need to raise the bottle height much higher than a regular case, because the fluidics is considerably altered. Once the nucleus was prolapsed into the anterior chamber, it was gently removed with the phaco sandwich technique. So we heaved a sigh of relief, did the cortex aspiration and injected a foldable intraocular lens for this patient. Post-operatively, she regained a visual acuity of 6/9. So this was not only a regain of sight for this patient, it was a journey where she regained her financial independence. Her main concern was that she couldn't sign checks because her sons were living abroad. So now she's getting ready for a second surgery for the other eye. So it's important to consider all the options in a special case and do what is possible with your skills and the situation. Thank you.
We treat the most common condition, cataract, in the most perfect way, and that's what she has done. Great presentation. I can see the audience stunned in admiration. Now wait for the next Queen of Quailon. I call upon next speaker, Rakhi Cruz, seasoned and weather-beaten to win always. Again, our regal queen.
भाइयों बहनों सुनो एक कहानी। एक लड़की थी दीवानी सी, एक लड़के पे वो मरती थी, पर आजकल उसको देखने के लिए इसकी आंखें ठीक नहीं दिख रही थी। So this breathtaking beauty walked into her OPD, complaining of blurring of vision for near and distance for the past 1 week. This beautiful lady had a dark history. She was a known case of sickle cell disease on treatment for the past 8 years. Recently recovered from SARS-CoV virus infection 1.5 months back. She had bilateral lung involvement and she was admitted in the ICU. So upon her examination, her uncorrected visual acuity was 20/40 in the right eye, 21/25 in the left eye. Rest everything was normal. Fundus examination revealed a dull grayish-white yellowish lesion surrounding the fovea with an irregular margins. So since she had a recent history of fever, we thought maybe it is a foveolitis, maybe it is a post-fever retinitis, or maybe it is a PAM lesion. So foveolitis, as we know, is usually associated with dengue NS1 and can be associated features like retinal superficial hemorrhages, yellowish patches around the fovea. Post-fever retinitis, usually there will be a recent history of fever. Along with that, there will be other features like disc edema, yellowish white retinitis patches, and hemorrhages. So we went ahead and did an OCT, and jingalala, we got the diagnosis. So there was this hyperrefractive band faintly occurring at the deep capillary and the intermediate capillary plexus, and Octa also showed signal void areas, especially involving the deep plexuses, along with widening of the foveal vascular zone. FFA did not show any capillary leakage or staining. So we came to the Dhamakadar diagnosis of paracentral acute middle maculopathy. So PAM, as we know, preferentially involves the deep retinal capillary system, especially the intermediate and deep capillary plexuses, where impaired blood flow occurs, and particularly the anatomical and the physiological watershed zone is affected. So COVID, since its inception, has been affecting the eye, first in the form of conjunctivitis, then started involving the retina. There were multiple papers on veno-occlusive disorders. But then there was this paper by Marino et al. Who showed that in most of their cases, there were these hyperreflective lesions at the level of ganglion cell layer and the inner plexiform layer, more prominently at the papillomacular bundle. Further investigations revealed everything to be normal except for a raised D-dimer level. So this raised D-dimer level may be to the post-COVID status. So she was sent again to the physician and was started on injection enoxaparin and hiked oral steroids. പിന്നെ ഞങ്ങളുടെ തന്നെ സമാധാനത്തിന് വേണ്ടി ഞങ്ങൾ ഇരുന്നൊരു ഹൈപ്പോത്തിസിസ് അങ്ങോട്ടും ഉണ്ടാക്കി. So this girl had bilateral lung involvement due to COVID infection, which led to hypoxia. Hypoxia led to increased sickling. Along with that, what happens in COVID? COVID has a special love towards the ACE2 receptors, which is easily available in the retinal vascular endothelial cells, which can cause direct damage to the cells. Along with that, the real villain, the D-dimer, caused microthrombotic alterations and resulted in PAM. So she was started on injection enoxaparin and steroids, asked to review with repeat D-dimer levels. So on follow-up, her D-dimer levels became normal. PAM lesions also resolved. So finally, this beauty walked out of her OPD with a 20/20 vision, and now she can see her boyfriend clearly and sincerely. Thank you.
So ladies and gentlemen, let's move on to the next case, which is called a Navarasa case, in which a surgeon gets all the Navarasas like joy, anger, love, passion, everything in one case. And we can learn from the mistakes which have been made in this case. See, we know all these rasas exist. How does it get created in this case? Starting with this case, love, very nice case. Good rexis and good phaco going on, confidence building up. And we reach a stage of big confidence and it keeps on going. Now suddenly you see a red glow and tilting and something happens and you stop. And then comes the question of astonishment. What is happening here? And then if something is wrong, you turn, you extend incision and then try to convert. So that is one thing which we are planning to do now. And then we are looking at the nucleus which is now into the vitreous and landed almost into the mid-vitreous. That has been searched there, and then you can see the capsule also open up there in the center, and I'm trying to fish out some of the nucleus, and now I am in deep sorrow. And I take out what is left in the anterior chamber, pulling out some vitreous also along with it, and then there is one piece which is still left there. And I tap on it, suddenly comes out. And I'm so very happy, and we reach a stage of joy in this stage when we have taken out all this nucleus. But then you suddenly realize that there is one more which is sitting there still. So I again go in with a vitrectomy probe and try to find out whether it can come out. It has come up. And I stop irrigation, try to shallow the chamber, and then press again. And it again comes out. One more piece come out, joy. This is ultimate joy. And then you try to put more viscoelastic inside. Viscoelastic goes into the vitreous and then push out this piece, and I am happy. And then vitreous is all there. I can cut off any vitreous, but suddenly one white glow again comes up, and it is scaring me. But I am still very confident that something is okay. And then it is fear still. But then I can now try and find out again one more comes out. I don't know from where. It's retina. It's not retina. Anyway, it is nucleus. It's still coming out. Disgusting it is. But then still, I again try, go in with my vitrector, little deeper, again it comes, but finally it goes away from me. And now I am angry. I keep on cutting off this silly vitreous from everywhere. And then I become confident now that I can try to identify what is left there, the capsule. There may be the anterior capsule which is left. Now I can identify that the capsule is still there. And then I always keep my 3-piece IOL backup, and the 3-piece IOL goes into the sulcus to place on top of the rhexis margin. And that makes you good, and then this patient can be referred to the retina clinic, to the VR surgeon, to manage that small bit of nucleus which is there in the vitreous. And now it is peace for me, Shantam. And now what have we learned? We have to learn from this case. Now what is there? Hidden posterior polar cataract might be there. We have to do a good posterior capsule rhexis and anterior capsule rhexis. Don't withdraw. Always convert at a newer location, not cutting, extending. And then hemostasis is a very important thing. And blood should not go in. Identify vitreous in the AC, and use triamcinolone if required, and do not fish in the anterior vitreous phase, and do not drag vitreous while you are taking it out, and bimanual vitrectomy not through the main incision, and avoid AC shallowing and vitreous prolapse, and no HPMC into the vitreous, and we have to plug it with sodium hyaluronate to avoid vitritis, and identify vitreous band and cut them well, and let go of the pieces which have gone into the mid-vitreous, and have the VR backup very much along, and identify the capsular rhexis and the rhexis availability, and place the 3-piece lens which should always be there with you, and have a good rapport with your VR surgeon like Gopal, which is our very good friend. But whenever we go with this kind of a problem to them, they will have this kind of a look with you, and they will, for them, we have to take them to shops everywhere and have a good relation with these people. Thank you very much.
Thank you very much. A big round of applause for them. Can I have the beautiful young ladies here, please? ये क्या आप लोग, you are looking at positions. Which position? She wants it in the.
Do a cataract surgery.
No.
1970?
No. She is looking at positions. She is looking right in the middle, and he is looking at enjoyment, disgust,
Beautiful lady, 18-year-old.
and they don't know they come from the land of Vatsayan.
Sir, I thought this was Uganda Ophthalmic Club.
Uganda?
Oh, yeah.
What?
I mean, sir, this is 1970s surgery. One lady is coming, and then they are putting her in a wheelchair, and they are frightening them. This will happen, that will happen, and then blocking. This is the age of topical anesthesia, simple 2-minute, 3-minute cataract. 2 minutes, 3 minutes. What is your...
Gopal wants only quickies. 2 minute job.
No. So,
we didn't frighten you. You got
and
frightened.
The second case, sir.
You only got frightened. We didn't frighten you.
You
only got frightened. We didn't frighten you.
No. Are you using some well to take the water out? Are you doing vitrectomy or cataract surgery? What is it? And then you will refer to retinal surgeon. Retina is like doing like this.
See, you should understand
what is this?
You should understand how to an idea of physiology, please don't talk.
And our beautiful little girl was like, I've got a show and tell.
That's what our beautiful ladies do.
Thank you very much, beautiful ladies and young and old men. Thank you very much. A big round of applause for them. And we now we now have the last team, but not the least, right? So you can see through your dark glasses, right? Sure? Okay, all yours. Is the team ready?
Polarized glass.
Polarized progressive glass. How much did you got bribed by the chashma wala?
I have my own chashma.
Okay, good. So let us, are you guys ready? Are you ready, sir? Can we start?
Okay.
Huh?
Okay.
Yeah. Can we
Ladies
start
and
the timer,
gentlemen,
please?
meet our team, Trishur Tornadoes. Watch them in action. Taste the thunder. Over to the video.
Good to go, Chief.
Okay, Dr. Lediga from Amala Medical College, Professor HOD. She will be talking a tale of triple twist.
So, yeah, good afternoon, everybody. And at the onset, let me thank the Scientific Committee KSOS for this opportunity. This is not a case, it is not a case series, but it is rather both rolled into one. So let's go into it straight. This story begins with an emergency call that we got from the OBG saying that a 24-year-old lady who had undergone LSCS just 5 days back, complaining of blurring of vision in both eyes. So we find that the right eye has a 6/24 N10 vision and the left eye has a 6/9 N8. There are no other features in the anterior segment, but the fundus shows bilateral submacular detachments confirmed by OCT. In the right eye, it was a subfoveal detachment, and in the left eye, a slightly temporal parafoveal detachment. So our thoughts were hovering around, is this a bilateral CSCR because the patient was pregnant, she had hypertension and she had steroids. The LSCS was done for an emergency PT. So all these can lead to CSCR. So we also was thinking of a bilateral exudative RD, though the indirect did not show up any multifocal detachments. And in the back of our minds, there was this posterior reversible encephalopathy syndrome, which is nothing but a reversible cortical type of visual loss due to a reversible cerebral edema, which can be pinpointed only by an MRI, but which the patient refused at that point of time. So we decided to control the systemics and wait and watch and ask for a follow-up after 2 weeks. 2 weeks later comes the first twist in the tail, where we meet the patient not in the ophthalmology but in the neuro ICU with a lacunar stroke. She had a lacunar infarcts in the right corona radiata as well as the right occipital cortex. But thankfully, the vision was near normal, the anterior segment was normal, the macula was dry, there was no SMD, but there comes the next twist in the already twisted tail. We have a surprise waiting for us in the fundus, though there is no SMD. We have, in the course of the 2 weeks, the patient has developed a right inferotemporal branch retinal artery occlusion. And we also did a field because we were expecting some homonymous field effects on the left side, but there were not any. The fields just showed a field effect corresponding to the inferotemporal BRAO in the right eye. So I learned something from this, that is, lacunar strokes have a very good prognosis. They don't affect the white matter at all. They don't leave field effects. So don't be under the impression that all cortical lesions have field effects. So after 4 weeks, we just saw the patient again. Everything was normal. Only the fundus showed features of an old BRAO. So we have a patient whose journey started with an emergency LSCS for severe preeclampsia. In the first week, her retina is in trouble. In the second week, her visual pathway is in trouble. In the third week, her vascular tree is in trouble. The retinal vascular tree is in trouble. So when we have a sequence of events like this, we have to look beyond the eye. So that's why we did a cardiology neurology evaluation. They started on tabecosprin and a complete hematoimmunological profiling was done. It was advised after 3 months after pregnancy. There comes the third and the final twist in the tale, because we saw a happy young mother with a stable fundus eye and vision, but she came out to be antiphospholipase antibody positive. So for once we have a happy patient, and for her it is a happy ending. For her it is probably the end of the story, but for the clinician we are a bit worried because it can be the beginning of many twisted tales, because APLS can have all this. We are worried, our fingers are crossed, from where we are going to get another call, from where we are going to meet this patient again, in which ICU we do not know. So the takeaways from this case were, pregnancy is a risky time and one pathology does not exclude another. Many can coexist. All SMDs in pregnant females are not CSR, so do not hesitate to investigate. And in young patients with multiple vascular events, expect the unexpected, do a complete immunohematological profiling, team up with the other specialists also, because eye is not an island. Thank you.
Over to
Next
Saji
video.
Hussain.
Next video, please. Shaji. Yeah, so this is about a double trouble I had, and my case is about a lady, 30-year-old, who had presented to me with a perforated corneal ulcer. She was on treatment from elsewhere for the past 2 weeks. So now a diagnosis, as you can see, there is a perforated ulcer. The size is around 5 by 3 millimeters, and the perforation is around 2 by 3 millimeters. So now a scraping was done whether to rule out whether this is an infective or an non-infective, because the management line would differ accordingly. So this seems like a very simple case to begin up with. So let's say if this was an infective case, the plan is to start the patient on fortified drugs, and depending upon the basis of healing, we can plan a therapeutic keratoplasty accordingly. And if this is a non-infective, the plan is either to go about with a patch graft, T-nons patch graft, or a glued BCL. So now after, let the results of the scraping come, and accordingly, the plan here was gram staining a KOH bond presumptively negative. So I have given a diagnosis of a sterile corneal ulcer here, and the culture reports are awaited. So here the plan of action would be to go ahead with a patch graft, since the ulcer is quite big, to do a T-nons patch graft or a glued BCL. So depending upon the size of the defect, the decision was done not to go ahead with the T-nons or glued BCL. So the plan, how to go about with the patch graft here would be remove the diseased area and replace it with a clear donor cornea and suture it at the area with 8 sutures. So the case was posted, and the next day morning, it was the last case in my OT list. After a long day, I was really tired and was looking just ahead to finish up this simple case and head back home. And I have to say I was a little bit of in a hurry. I was really too tired, and I was just a little more stronger. I was applying and trying to go about with a little bit more, and this just happened. And make sure you don't scream. Rule number 2, never shout, and please never show to the patient that you are stressed. Can you raise up the volume a bit? So you have to think about Baba Ranjur Das. What he usually tells me is, keep your heart and say, all is well. All is well. All is well. All is well. Just cool down. Relax. Yeah, and that's Baba Ranjur Das's deep words. So I went ahead according as planned. I placed the graft and sutured. The first 4 primary sutures is very important. All along the way, I have to separate the iris as well as the nucleus material all along. And ensure that the iris is not incarcerated through the defect. The bleeding, everything is, and your pulse rate is hitting at 200. And the last suture, ensure the air bubble is formed. And the patient was seen post-op. It was taking up, the AC is a little too shallow, and I waited for at least 3 months, and then went ahead with SICS. So the initial plan, a scleral tunnel was done. The pocket of up to the scleral tunnel was made. I made very small entry, thinking about the how dense the nucleus would be. stained the capsule, did a good neat rhexis, and delivered the nucleus into the anterior chamber. And I realized it's quite a soft cataract, so I did a IA and aspirated the nucleus out and cleaned up the cortex and placed the IOL in. Dialing it all along the loose bag, everything was hitting hard. And from the AC, the patient is currently having 6/12, IOP is 18, and so far managed well. Thank you.
Over to Dr. Marine Ball.
Thank you. So this was one of those days when I was very happy to be a cataract surgeon. And we started off, I said, just play the video. Yeah. So I said, okay, small pupil, no issues, I'll handle it. I put in my iris hooks. I say, okay, that is all that I have to deal with today. And I make my incision, and then I find when I touch the anterior capsule that the whole lens is wobbly. So what am I dealing with here? It is also a case of extensive zonulopathy. So at this stage, I realized that I will be in big trouble if I do not stabilize the lens with my second instrument, and I used an Utrata to make the rhexis. And as I am making the rhexis, I noticed those folds on the anterior capsule, which is definitely a sign of grade 3 zonulopathy. So when you are making these, in these cases, when you are making the rhexis, you need to be extremely careful to keep on providing counter traction, as I am doing now, to keep those weak zonules in place. Otherwise, the whole thing is going to go down into the vitreous. So once my rhexis is complete, I take a deep breath and then go in for the hydrodissection. And I make sure that I do not do a rotation in these cases of the nucleus, because already the zonules are really very weak. So instead of using capsular hooks, I use my iris hooks to suspend that capsular bag with the iris hooks to provide stability to the entire bag. And once this bag is stabilized, I plan to do a very low parameter. I brought down the bottle height, and I was hoping that this lens would be a smaller, a softer lens. But to my horror, when I go in, I find that the nucleus is a grade 3 hard one. So instead of my regular chop, I shift to a stop and chop technique, and then slowly and very, very gently rotate that nucleus. And once those once those cracks are made in the nucleus, each piece is gently, very, very gently delivered into the anterior chamber, and the phaco is completed with a very, very small parameter. Now coming to the last piece, I realized that the entire posterior capsule is extremely lax. I could have put in a CTR at this stage, but at that point, I thought that an IOL scaffold will work for me better, and therefore I put in IOL scaffold and phacoed the last piece at the pupillary plane, and then put in the CTR to stabilize the capsular bag. And once that bag was in place, I'm sorry.
Your time's run out, ma'am.
Okay, no problem.
The lens is in place, everything is good. Okay. Big round of applause for the team, please. Great. Can I have all the team members please come on the dais, please? Can I have all the team members to please come on the dais? So we will start with the audience poll, right? So are you ready for the audience poll? We will have the audience poll for the best individual presentation, please. So audience, how much time will you give the audience? Sai? Sorry? How much? Yeah, show the slide and then tell me the time.
Anant, QR code on stage. QR code.
Why are you already giving the marks here? They can start?
Hey, stop.
Huh?
Stop.
Okay, anyway,
Can,
we will have
can
one
people
more.
vote now? Okay, yeah, please vote and your time starts now for whatever. I think 15 seconds will be more than enough for the best individual presentation, please. Best individual presentation. Sir, Ragini, Dr. J.K. Reddy. Oh, okay. So, would you wish to, come. Just, can you stop the, Sai, can you stop the vote count now? Okay. So can we have the winner now for the best individual yeah, they will. Go ahead. Yeah.
See,
So any guesses? Any guesses? You guys have voted. Any guesses? No guesses? दिखा दो यार, बड़ा सस्पेंस कर रहे हो. Good. Oh wow. So Dr. Meenu is first. Congratulations, Meenu. Please, can we, Dr. Lahane, have the trophy? And the second goes to Dr. Sujit. So Dr. Meenu and Dr. Sujit, please. So that's for the runners-up, individual runners-ups. Dr. Sujit, please. Dr. Sujit, please. Dr. Lahane, please do the honors. A big round of applause for Sujit, please. Fantastic.
Thank you.
Come. And Meenu, the ecstasy for you. Congratulations. A big round of applause, please. वो जेकी चला गया. Okay. Good. So now, are you ready with the, Are you ready with the results from the judges or no? Okay, fine. It'll take 5 minutes. Dr. Lahane sir, would you like to comment on the presentations?
The presentations, see, it is a OPL. In scientific, we are there for 3 days, we are doing scientific. It is a playing. And that everybody should laugh whenever there is a presentation is going on. So when there is a complication, you must keep that for the OPL. So what has happened, except nobody has nothing in that. So thus they were presenting the science. Science we see other presentation. In OPL, science plus entertainment. That is what is called as a OPL. So I think this is first time, but very well managed. And I think you will add humor in the presentation. Next time, humor in the presentation. Good. Thank you.
Thank you very much, Lahane. So, humor and tumor. Right, Natasha? Good. Are we, can we go on to the, again, voting, please? Can we have the voting and don't show it, please? We want to have the voting for the best team and the runners-up team. Can the voting be put on? Please use your phones, smartphones for the voting, please. Another 15 seconds. Okay, can you stop the voting now? Any guesses? Malabar, Malai Mal, I don't know. Don't.
Let us see the results.
I hope it's not premature. Okay, so everyone is rooting for Malabar. Sai, can we have the results, please? Malabar! Yeah. And who is the runners-up? Sola. Kochi. Yeah, Kochi with 19 votes. Yeah, Kochi. Okay, so can we have the trophy for the runners-up? Ragini, runners-up, audience, Kochi, Avengers. Come, आइए यार. Come. नीचे.
Congratulations, Kochi. Can we have the Malabar? Congratulations, please. Big round of applause for them. Thank you very much. One second. Abhi hai, all teams please stay back. Abhi you can get some more prizes please. How long? Do you have the team thing done? We can announce the team or no? Huh? What? Okay, let's take a picture first. अभी इंतज़ार की घड़ियां बची हुई हैं क्योंकि जो जजेस हैं वो तो ब्राइब पहले हो गए थे, अब जो काउंट कर रहे हैं उनको ब्राइब मिल रही है. आप सर फोटो के लिए आ जाइए. Come. Come, we are waiting for you to make the picture. Come. Okay, so friends, we have the judges' choice. सर आपने भी थोड़ा सा तो इंसाफ कर ही दिया, पूरा इंसाफ कर दिया. तो बेस्ट एंटरटेनर, सॉरी, can I get the best entertainer? This is scientific presentation. Any guesses for best entertainer, judges? बोलो. Meenu, yes. Come on. Big round of applause for him. Okay, so we go on to the best scientific presentation, and that goes to, any guesses? Dr. Prakash. Same and second.
Second individual runner-up will be too much of totaling, sir.
Okay, give it to her. Okay, so best individual runner-ups. for the beautiful lady Rakhi, the crew. Good. So now we have the individual champion for a combination of everything. Minu, you need to hire a truck. This comes again to you. Individual champion, congratulations. Minu is feeling shy. Big round of applause for him. Too many victories. You want to say something about so many multiple times you are getting ecstasy?
On a serious note, this is just the beginning. He is going to beat Mohan Rajan's record now.
Oh, great. Okay, so finally let's see judges, sir. Aapka. सर जजेस आपको थोड़ा बहुत पैसा मिला है थोड़ा बहुत पैसा मिला है क्योंकि मालाबार को इतनी ओवरवेलमिंग मेजॉरिटी से जिलाया था थोड़ा मिला है ज़्यादा नहीं कितना मिला रागिनी 1 लाख के एक खोखा के एक पेटी ओके सो अकॉर्डिंग टू द जजेस द रनर अप टीम इज टीम मालाबार according to the judges. A big round of applause to Team Malabar. Please, can we have the trophy for the runner-up? The beautiful trophy for the team runners-up. Come. Okay, thank you very much. Now the final trophy. Ab judges ka, what do you feel? Who will be the winners for them? Sorry? Travancore. Chalo sir, ho gaya theek. So the best team according to the judges is Team Travancore. A big round of applause, please come.
Three cheers to Mahipal sir. Please clap for him.
Hooray! Hooray!
Cheers to KSOS. Cheers to
Thank you very much and thank you KSOS, Srini, thank you Raj, everybody. We had great fun as much as you had. Thank you.
बैल जैसे धूल उड़ा के सींग उठा के तुम भी नाचो बाज जम के ताल ढोल बेटा राजू उड़ के नाचो हीरो से भी तेज कोई कर सके जो बेद नाचो अस्तबल में घोड़े जैसे भाग डोर छोड़ नाचो जो तो रोट मोटा मिर्चा खा के ऐसे नाचो हाँ जा छोरे हाँ जा गोरे हाँ जा छोरे नाचो 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 वीर नाचो 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 यार नाचो 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 कच्ची कैरी जैसा खट्टा नाचो 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 बिच्छू काटा लागे ऐसा नाचो ना देखा नाका ना गिना देखा चिकनी चमेली देखी चिकना कमीना देखा चांदनी चिडर होके चीट किया तो सारे तारे बोले गिली गिली अखा बदतमीज दिल माने ना बदतमीज दिल माने ना My lady Papa Zenny, out of lady popping Molly, why she waiting on me? You're in my area, keep on heading if you want, I drive it like a nut. I don't wanna hear you, just ain't you know, like I'm Bango, cutting my hair, I just keep going though, so she's gonna make
So in the next session, the 5 tips from the masters is going to be something that you should not miss. These are small changes in techniques that the best surgeons in India have made to their techniques to get a perfect result. And FEICO will start at 4 o'clock, be back by 4.
I'm not gonna lie, rather had fun on Yagi, her brain fried. My lady Papa Zenny, out her lady popping Molly, why she waiting on me? You're in my area, keep on heading if you want, I drive it like a nut. I don't wanna hear you, just ain't you know, like I'm Bango, cutting my hair, I just keep going though, so she's gonna make